So, if a patient's depressed, you have to ask them about suicide. And if they have intent and/or a concrete plan, you need to think really hard about whether or not they're safe to let out of the hospital. The risks are nicely summed up in the mnemonic SAD persons. People most at risk for completing suicide attempts tend to be male. Their age is bimodal, with suicides peaking in teenage years and in the elderly. And of course, depression predisposes to suicide. Other risk factors include previous attempt, alcohol or drug use, extreme emotion or anything else that impairs rational thought, chronic illness and polypharmacy, and having an organized plan. Being alone is also a huge risk factor. Having no spouses or social network of any kind can cause isolation that can serve as a risk factor for suicide. The next segment of disorders is the anxiety spectrum. While generalized anxiety disorder is the one everyone knows about, this group of disorders actually involves all disorders that cause an inordinate amount of fear or worry. This includes panic disorder, specific phobias, obsessive-compulsive disorder, and post-traumatic stress disorder. So, I'll give you one guess as to what the first-line treatment is for all of these. Hint, it's something you've been saying a lot so far. The first-line treatment for all of these disorders is SSRIs and CBT, followed closely by the SNRIs, and that's pretty much the best part about anxiety spectrum disorders. The treatment is predictable. Benzodiazepines are probably the best known drugs for treating anxiety disorder. Any guesses as to why they're not used more often, why they're not first-line drugs? The reason is because they're super fun, but also super addictive. That being said, they're arguably the most effective anxiolytics, and there's definitely a lot of good uses for them. The first two on this list embody non-specific anxiety, and like with the mood disorders, they come in an episodic and a chronic flavor. The other three are instances of anxiety disorders caused by specific triggers. Let's start off now with panic disorder. So, I don't know if I mentioned this to y'all, but I'm going into emergency medicine next year, and I gotta tell you, we hate panic disorder in the ER. Why is that? Because one of our main jobs in the ED is to rule out the things that'll kill you. And panic disorder is capable of presenting almost exactly like a handful of life-threatening complaints. A panic attack is acute onset, lasts on the order of minutes, and frequently feels like the patient's about to die. Now, I don't think it's particularly high yield to memorize the exact list of somatic symptoms that characterize panic disorder. Instead, I like to think it's more helpful to understand what panic attacks can look like if you didn't know you were dealing with an anxiety spectrum disorder. A panic attack can easily resemble a heart attack or an arrhythmia, complete with chest pain, palpitations, diaphoresis, and lightheadedness. It can also look a lot like a bad asthma attack, complete with shortness of breath, lightheadedness, and a choking sensation. It may seem primarily gastrointestinal, presenting with non-specific epigastric pain and nausea, and if that doesn't sound life-threatening to you, by the way, then you should know that in the elderly, a visit to the ER for abdominal pain is actually an even more lethal complaint than chest pain. Finally, there's a bunch of non-specific sympathetic nervous system complaints, like headache, dizziness, shaking, chills, and paresthesias, that can warn of impending badness. And according to the patient, this feels like it's all bad. A lot of the times they feel like they're going to literally die or go crazy. So, here's the thing. While the diagnosis of panic disorder only requires one panic attack, it also requires at least a month of anxiety and/or behavior change that stems from worry about the panic attacks. While panic disorder gets the same treatment as the rest of the anxiety spectrum disorders, acute panic attacks happen to be one of the best reasons to have benzodiazepines handy. A fast-acting benzo can pretty quickly put an end to a panic attack, while SSRIs, on the other hand, need weeks to take effect. But for the long term, you're still going to want to use your CBT and SSRIs. The real reason panic disorder is a pain is because there's no test for it. So in the ED, you literally have to rule out all the other horrible possibilities before you can call it panic disorder. On step 1, on the other hand, where you have to go with the most likely answer choice, it's pretty safe to say that a woman in her 20s with chest pain and diaphoresis is more likely to be having a panic attack than an MI. You'll have to use your clinical judgment to figure out what's most likely, but you should always keep panic disorder on your differential diagnosis. Specific phobias, as you'd expect, are irrational fears of very specific things. The response can be anywhere on the anxiety spectrum from mild anxiety to a full-blown panic attack. Animal triggers, like snakes and spiders, are pretty common, but triggers can also include situations, like social anxiety disorder, the fear of public embarrassment. Triggers can also include environments like agoraphobia, which is the fear of an uncontrollable environment. Examples include crowded spaces, wide open spaces, or even public transportation. Now, agoraphobia in particular is strongly associated with panic attacks, and if you think about it, if you never knew when you were going to freak out, I bet you'd be pretty reluctant to get on a crowded train as well. Most specific phobias don't actually need to be treated with pharmacotherapy. In fact, the best treatment is usually just to systematically desensitize the patient to the trigger. Like have them get closer and closer to a snake until they can finally kiss it without freaking out, or something. I'm not a psychotherapist. But both social phobia and agoraphobia generally benefit from the classic anxiety disorder cocktail. Remind me what that is again? SSRIs and CBT. There you go. In addition, agoraphobia responds pretty well to the MAOIs. And why aren't these guys first line again? Bad side effect profile. Seriously, for how annoying I'm being right now, you guys are seriously going to be so happy I was a pain with these questions. This is seriously high-yield information. Generalized anxiety disorder is basically at least 6 months of anxiety that isn't related to any specific trigger, but is more of an all-pervasive worldview. Now, this might seem like a pretty vague description as it's defined in first aid, but you really don't need to know any more about it than that. If you're a little curious or just too type A for your own good, the DSM-5 diagnosis is kind of like panic disorder in that it's based on psychosomatic sequelae caused by the anxiety, like irritability and muscle tension. Now, this is the most common white bread anxiety spectrum disorder, and the treatment's exactly what you'd expect. Of note, a couple of relevant second-line drugs are buspirone, which is a great non-sedating anxiolytic, and the TCAs, which are also used as antidepressants. Benzodiazepines are worth a special mention here because even though they were the quintessential anxiolytic back in the day, it's considered super irresponsible to use them for long-term anxiolysis nowadays. I mean, it's one thing to use them every now and then to head off a panic attack, but years of maintenance dosing with benzos is super not alright. First of all, because of the obvious dependence and addiction potential. Second, because of the dangers of sedation. But as we discussed in neuro, what's one other major use for the benzodiazepines? They're anticonvulsants. And because of that, tolerance to benzos will gradually decrease your natural seizure threshold because your body's like, I guess I don't have to worry about preventing seizures anymore. Then years later, if you try to come off your meds, it could actually put you into full-blown status epilepticus until you get your fix. Not cool. Now, this is as good a time as any to talk about adjustment disorder, which will forever be a plague on your psych differentials. Even though we're talking about it in the anxiety section, adjustment disorder can present as pretty much any magnitude or combination of anxiety or depression symptoms. And like the name suggests, it's caused by a poor adjustment to a new identifiable life stressor and must end within 6 months after the stressor is removed. Let me make that clear. It's not a rigid 6 months. If the stressor persists, adjustment disorder can theoretically persist indefinitely. But once the stressor ends, you've got about 6 months to get over it, otherwise you can't technically blame it on the stressor. Adjustment disorder is important on your psych differentials because of the range of symptoms it can present with, and it's particularly important to distinguish it from generalized anxiety disorder and major depressive disorder. The most obvious difference would seem to be the stressor, and while it's true that GAD and MDD aren't necessarily brought on by a stressor, it's absolutely possible, and in fact pretty common, for a life stressor to be the thing that kicks off either disorder. So, just because you see a life stressor in the vignette doesn't mean it's necessarily adjustment disorder. So, what is the number one reliable way to distinguish it from GAD? The answer is the time frame. That makes distinguishing the two easy on you. If you've got anxiety symptoms that aren't trigger-specific that were started by an identifiable stressor, then it's called adjustment disorder within 6 months after the stressor ends, and GAD after 6 months has passed. Finally, GAD requires the presence of psychosomatic symptoms, but I gotta be honest, this isn't usually a wonderful way to distinguish between the two. Because the time window for a major depressive episode is only 2 weeks, there is a significant time overlap, but you can still use the timing to help you distinguish between the two. But just like with postpartum blues and bereavement, the diagnosis of MDD trumps adjustment disorder. Basically, if it meets major depressive disorder criteria, it's major depressive disorder. Again, why do we care about these stupid semantic distinctions? Because it can affect how we treat. Adjustment disorder is by definition self-limiting. The first steps include addressing the stressor, either by removing it or learning to deal with it through therapy. If the symptoms are severe or persistent enough, it can be treated like GAD and MDD with, you guessed it, SSRIs and CBT. So the question is, what are the two general diagnostic requirements for panic disorder? And I don't have a cow, you guys. I know I just told you that you don't need to know the criteria for panic disorder, but I'm talking about the two basic general diagnostic requirements. Pause if you need a moment to think about this. So the two general diagnostic requirements, first of all, to have panic disorder, you need to have at least one panic attack. Now remember, a panic attack needs to have somatic symptoms associated with it. You can either memorize the panics mnemonic, I can't even remember what that is, but basically it can mimic an MI, an arrhythmia, asthma, GI symptoms, or a pseudo-neurologic disorder. And these are oftentimes accompanied by a feeling of impending doom or insanity. These patients really think they're going to die. Secondly, panic disorder requires at least 1 month's worth of preoccupation with the panic attacks. This could be constantly thinking about the panic attacks, constantly worrying whether you're going to get another panic attack, or even just being slightly off or irritable or on edge for an entire month surrounding the panic attack. OCD is another one of those disorders that has a far different lay definition than its diagnostic criteria suggest. The disorder is defined by the presence of obsessions, compulsions, or, most commonly, both. Obsessions are specific anxiety-provoking thoughts that keep popping up. Even when patients try to put it out of their heads, they tend to keep coming back. Patients may try to focus on something else, but generally, the anxiety is only alleviated by performing the corresponding compulsion. So these tend to be pretty time-consuming and disruptive, so patients will generally seek help for this. Can anyone guess what the treatment is? Apart from your usual cocktail of SSRIs and CBTs, the TCA clomipramine actually happens to be pretty good at controlling OCD. Now, OCD is one of those terms that people like to throw around like, oh my god, I'm so OCD, I can't stand the fact that this PowerPoint's asymmetric. And what they're so poetically referring to is actually more similar to OCPD, or obsessive compulsive personality disorder. See, people with OCD know that their obsessions are nuts. That's called an ego dystonic obsession. People with OCPD are convinced that they're right, that the world should ideally operate their way and that I need to pay more attention to how I make my slides. That's called an ego syntonic obsession. Next, remember what other disorder OCD is associated with? From the childhood disorder section? It's Tourette's syndrome. And I remember this by the fact that they both have to do with repetitive behaviors. Finally, body dysmorphic disorder is a specific obsession with a perceived physical defect. It's not the same as anorexia, which is specifically weight-related. The thing to remember is that these guys really need therapy. They may come in looking for cosmetic surgery a lot, but rather than cut them open for a few bucks, the ethical thing to do would be to send them to a therapist. Post-traumatic stress disorder is an anxiety disorder that results from psychological trauma. Now, I know what you're thinking. Isn't that pretty similar to adjustment disorder? Well, as it turns out, the DSM-5 is pretty specific about what it counts as trauma, rather than just a stressor. And the pattern of symptoms is a lot more specific than just a loosey-goosey, it can be anything definition for adjustment disorder. First, the trauma has to be either death or serious injury, as experienced by soldiers in combat, or sexual violence, as experienced by rape survivors. Generally, the patients have to have directly experienced or witnessed the trauma firsthand, or at least come very close to doing so. Now, what do you think of when you imagine the symptoms of someone with PTSD? Generally, people think about flashbacks as the hallmark of this disorder, but that's only a part of the picture. Re-experiencing can take not only the form of flashbacks, but also nightmares. The other characteristic symptoms include avoidance of stimuli that are associated with the trauma, and a persistent state of hypervigilance or hyperarousal. Now, like schizophrenia, the criteria for PTSD are time-dependent. In order to count as PTSD, the symptoms have to last for at least 1 month. Any less than that, and they get the diagnosis of acute stress disorder. The major difference is, while PTSD gets either the anxiety cocktail or an SNRI called venlafaxine, acute stress disorder is generally treated like adjustment disorder. Therapy only unless things get worse. Let's talk about somatization, which is the fancy word for a fake medical condition the patient made up. No, I'm sorry, that's mean. What I meant to say was medical conditions the patient swears exists, but doesn't. I guess that's not really a lot better, is it? Maybe this will explain it better. If a patient comes in with a medical complaint that doesn't actually exist, there are a couple of options. Either the patient really thinks there's something wrong and is mistaken, or they're telling a creative interpretation of the truth, shall we say. Now, obviously lying by itself isn't a mental disorder, just like being a jerk by itself isn't a crime. It just makes you a lame human being. When patients lie for normal reasons, i.e. to get out of work or jail or to get narcotics, we call that malingering. It's not a mental disorder, it's just annoying. So when is lying actually a sign of a mental disorder? Well, when patients do it for really weird reasons. Faking a medical complaint for no other reason than the fact that they crave the attention of being sick is kind of weird, especially when you consider the fact that these patients may mutilate themselves or cause themselves serious harm just to stay in the hospital and be sick. We call this factitious disorder, and there are two subtypes that you should know about as well. What I just described is called Munchausen syndrome, when a patient chronically fudges medical complaints. Munchausen by proxy is when a caregiver gets some kind of personal gratification from being the caregiver of a sick kid or elderly person. Now, how do you get someone else to act sick for you? Well, they can coach their kid or parent, manipulate them, or even deliberately hurt those in their care to satisfy their sick desires. Now, this is clearly not just an issue of a mental disorder. It involves psychological or physical harm to other people and is actually a form of abuse. Now, with regular Munchausen patients, you kind of got to treat them with kid gloves. They tend to get real upset if you call them out, and at the end of the day, you really do want to treat their mental disorder. But if a child's health or even life is at risk, then the kid gloves are coming off and you're calling Child Protective Services. They can talk to a mental health professional from their prison cell. Finally, the mental disorders where the patient thinks there's something wrong and really isn't. The most common one is somatic symptom disorder, in which the patient presents with multiple different complaints that never actually have a physical explanation. Illness anxiety disorder, also called hypochondriasis, differs from somatic symptom disorder in that the source of the problem isn't the complaint itself. It's the anxiety over what horrible zebras might be causing their otherwise mild symptoms. Here's the difference between the two. A patient with somatic symptom disorder might come in with an excruciating psychogenic stomachache, but a patient with illness anxiety disorder might come in with an actual stomach bug, but be absolutely convinced that he or she has a ruptured aortic aneurysm. Finally, conversion disorder is a specific somatoform disorder that occurs in response to a psychological stressor or trauma. Basically, the shock causes a pseudo-neurological deficit such as blindness, mutism, or limb weakness. The funny thing is, these patients don't really seem to care that they've suddenly lost their vision or whatever, which is funny because it sure bothered me. Now, you don't have to know a lot about these for step 1 because they're pretty uncommon. But what you do have to know is how to distinguish them and how to handle these patients. The absolute wrong way to do this is to tell them, hey, guess what? Turns out you're not having a subdural hematoma, you're just a hypochondriac. As I mentioned for Munchausen syndrome, these patients get really upset if you tell them that they've got a psychological disorder, especially when they really, truly think that they've got a legitimate medical issue. But what's the other really important reason not to write off their complaint? Well, as much as we all hate to think about it, you may be wrong. Not only do we make mistakes, but we choose which diagnostic test to run based on our pretest probability that the test will turn up something helpful. What if our patient really is the one 25-year-old non-smoking female who has a AAA? In other words, these diagnoses, the somatoform diagnoses, are diagnoses of exclusion, meaning you must rule out the life-threatening stuff first. With that possibility in mind, a nice non-committal step 1 answer is probably the best solution. Something like, you don't have anything life-threatening, but we can't quite seem to make sense of your symptoms just yet. That way you don't end up with egg on your face if their nothing was actually a something. Now this is a good segue to scheduling follow-up appointments with the primary care doctor, or you if you're the primary care doctor. That way you can not only follow up on their physical complaints to see if they actually have something wrong, but also start to get a sense of whether or not there are any life stressors that may be contributing to their somatization. That way you can deal with both of these if the time comes. Next, we're going to go over personality disorders, and really all you have to do with most of these is just be able to tell them apart from each other, and from the other mental disorders. But first, a little bit about what a personality is, and what it means to have a disordered personality.